Hello viewer, I am Muthusubramanian Ramasamy, a clinical clerk at Cebu Velez General Hospital. Welcome to my channel. Today, I'll briefly summarize Chapter 15 of the 20th edition of Harrison's Principle of Internal Medicine. The topic for today is fever. Here is the outline to today's video. We'll have a brief introduction to thermoregulation and a few quick facts to kickstart our discussion. We'll then proceed to define and differentiate fever and hyperthermia, understand the pathogenesis of fever, and how you should approach a patient presenting to you with fever. We will then discuss how to manage these patients, and I'll leave you with some facts to remember. Without further ado, let's begin. Body temperature is controlled by hypothalamus, specifically preoptic anterior and the posterior hypothalamus. These receive two kinds of signal, one from the peripheral nerves that transmit information from the warmth or cold receptor in the skin, and the other from the temperature of the blood bathing in the region. These two types of signal are then integrated by the thermoregulatory center of the hypothalamus to maintain normal temperature. The core body temperature is maintained in the range of 36.5 to 37.5 degrees Celsius. This normal body temperature is ordinarily maintained despite the environmental variation because the hypothalamic thermoregulatory center balances the excess heat production derived from the metabolic activity of the muscle and the liver with heat dissipation from the skin and the lungs. Here are some quick facts. The normal core body temperature is 36.5 to 37.5 degrees Celsius. Maximum oral temperature can vary depending on the time of the day. In healthy individuals, the maximal oral temperature in the AM is 37.2 degrees Celsius, while in the PM it is slightly higher at 37.7 degrees Celsius. This normal daily temperature variation of 0.5 degrees Celsius is called the circadian rhythm, and it's usually maintained even if the person is febrile, albeit at a higher value. Rectal temperatures are generally 0.4 degrees Celsius higher than the oral readings. The lower oral readings are probably attributed to mouth breathing, which is a factor in patients with respiratory infection and rapid breathing. Lower esophageal temperatures closely reflect core temperatures. It should be noted that certain populations such as newborns, elderly, and those with chronic hepatic or renal failure have blunted febrile response. Before we proceed, let us define a few terms. Fever is an elevation of body temperature that exceeds normal daily variation and occurs in conjunction with an increase in hypothalamic set point. Set point is the temperature set by the hypothalamus to which all temperature control mechanisms continuously attempt to bring the body temperature to. It very much resembles the setting of a home thermostat to a desired ambient room temperature. A fever of greater than 41.5 degrees Celsius is called hyperpyrexia. This extraordinarily high fever most commonly occurs in patients with central nervous system hemorrhages, but can also develop in patients with severe infection. The term hypothalamic fever is sometimes used to describe elevated temperature caused by an abnormal hypothalamic function. This rare condition could be brought about as a result of local trauma, hemorrhage, tumor, or intrinsic hypothalamic malfunction. Most patients with hypothalamic damage, however, have subnormal, not supranormal body temperatures. Although most patients with elevated body temperature are considered to have fever, there are instances in which they are not considered to have fever despite having a high body temperature. One such instance is hyperthermia, commonly known as heat stroke. Hyperthermia is characterized by uncontrolled increasing body temperature that exceeds the body's ability to lose heat. The setting of hypothalamic thermoregulatory center is unchanged. The increase in body temperature is brought about by two mechanisms, namely exogenous heat exposure and endogenous heat production. To help you understand, visualize this scenario. A construction worker is working on a hot sunny day at around 11 AM. His work causes endogenous production of heat from the muscles. Furthermore, the worker is also exposed to the hot environment, which is the exogenous source of heat. Due to this, at some point, the increase in his body temperature exceeds his body's ability to lose heat via vasodilation and sweating. Thus, he succumbs to hyperthermia. Note that the set point remained unchanged, hence this is not considered to be fever. This slide differentiates between fever and hyperthermia. Etiologies of fever include infection, local trauma, intracranial hemorrhage, and hypothalamic dysfunction. Hypothermia is primarily caused by exogenous heat exposure and endogenous heat production that overwhelms the body's innate ability to lose heat. Hypothalamic set point is increased to a higher value in fever while it remains unchanged in hyperthermia. Pyrogenic cytokines such as IL-1, IL-6, TNF are present in the pathogenesis of fever while they have no role in the pathogenesis of hyperthermia. Skin can be cold in fever due to peripheral vasoconstriction. It is, however, hot and dry in patients suffering from hyperthermia. Adequate treatment with antipyretics can decrease the body temperature in fever while it has no effect on body temperature of patients with hyperthermia. We will now discuss the pathogenesis of fever. But before we begin, it is important to know the following terms. The term pyrogen is used to describe any substance that causes fever. Exogenous pyrogens are derived from outside the patient. Most are microbial products, microbial toxins, or whole organisms. A classic example is the endotoxin produced by all gram-negative bacteria. Other examples include enterotoxin from Staphylococcus aureus and group A and B streptococcal toxins. Cytokines are small proteins that regulate immune, inflammatory, and hematopoietic processes. Hence, those cytokines that cause fever are called pyrogenic cytokines. They were formerly referred to as endogenous pyrogens. They include IL-1, IL-6, tumor necrosis factor, and ciliary neurotrophic factor. A wide variety of bacterial, viral, and fungal products induce the synthesis of pyrogenic cytokines. Furthermore, inflammatory processes such as pericarditis, trauma, stroke, and routine immunization can also induce the production of IL-1, TNF, and/or IL-6. As illustrated in the picture, myeloid and endothelial cells are the primary cell types that produce pyrogenic cytokines. Pyrogenic cytokines such as IL-1, IL-6, and TNF are released from these cells and enter the systemic circulation. These circulating cytokines lead to fever by inducing synthesis of PGE2 and also induce the production of PGE2 in the peripheral tissues. This increase in PGE2 in the periphery accounts for the non-specific myalgias and arthralgias that often accompany fever. Elevation of PGE2 in the brain starts the process of raising hypothalamic set point for the core temperature by triggering the PGE2 receptors on the glial cells, resulting in rapid release of CAMP, which is a neurotransmitter. The elevation of CAMP induces the release of neurotransmitters, thereby changing the hypothalamic set point. Once the hypothalamic set point is increased, neurons in the vasomotor center are activated and vasoconstriction commences. The individual first notices vasoconstriction in the hands and feet. Shunting of blood away from the periphery to the internal organs essentially decreases heat loss from the skin and the person feels cold. Shivering, which increases heat production from the muscle, may begin at this time. Non-shivering heat production from the liver also contributes to the increasing core temperature. Behavioral adjustment, such as putting on more clothes or bedding, help raise the body temperature by decreasing heat loss. These processes of heat conservation and heat production continue until the temperature of the blood bathing the hypothalamic neuron matches the new thermostat setting. Once that point is reached, the hypothalamus maintains the temperature at the febrile level by the same mechanism of heat balance that functions in the afebrile state. When a patient presents to you with fever, like any other condition, history and physical examination is the first step in the approach to the patient. In history, it is important to elicit the chronology of events preceding fever, for example, exposure to infected individuals or vectors, the characteristic of the fever, and any associated symptoms. Furthermore, patients' past medical history, specifically diagnosed chronic conditions and the maintenance medication being taken by the patient is obtained. This is important as a patient with chronic hepatic or renal failure, patients taking glucocorticoids, or are being treated with anticytokines may present with mild or absence of fever despite the presence of active infection due to blunted febrile response in this population. When obtaining temperature of the patient using oral or tympanic thermometers, care must be taken to use the same site consistently throughout the entire illness period. Furthermore, assessment of skin and other organ system might provide clues to the underlying etiology of the febrile disease. For the labs, CBC with differential count should be taken to identify the type of infectious organism causing the febrile disease. Peripheral blood smear may show juvenile or band forms, toxic granulation, or dull bodies, which are suggestive of bacterial infection. Neutropenia may be present with some viral infection. In patients with low-grade fever or with suspected occult disease, the most valuable measurement are the C-reactive protein level and the erythrocyte sedimentation rate. Remember, measurement of circulating cytokines in patients with fever is not helpful since their levels are often below the detection limit of the assay or do not coincide with fever. Treatment. The objectives in treating fever are first, to reduce the elevated hypothalamic set point, and second, to facilitate heat loss. Reducing fever with antipyretics also reduces systemic symptoms of headache, myalgia, and arthralgia. Acetaminophen, a cyclooxygenase inhibitor, which in turn reduces the production of PGE2, is a preferred antipyretic. Although acetaminophen is poor cyclooxygenase inhibitor in the peripheral tissue, in the brain, it is oxidized by the P450 cytochrome system, and the oxidized form inhibits cyclooxygenase activity. Moreover, COX-3 enzyme, unique to CNS, is also inhibited by acetaminophen. Oral aspirin and acetaminophen are equally effective in reducing fever in humans. However, aspirin can adversely affect platelets and increase the risk of Reye syndrome in children. Hence, it is not routinely used. NSAIDs, such as ibuprofen and specific inhibitors of COX-2, are also excellent pyretics, but their gastrointestinal side effects made their use less favorable. However, in children, acetaminophen and oral ibuprofen may still be used as antipyretics. If the patient cannot take oral antipyretic, parenteral NSAIDs or rectal suppositories may be used. Routine treatment of fever with antipyretics does no harm and does not slow the resolution of common viral and bacterial infection. Treatment of fever in the following patients is highly recommended. With every 1 degree Celsius increase over 37 degrees Celsius, there is a 13% increase in oxygen consumption. Hence, treatment of fever is recommended in patients with pre-existing impairment of cardiac, pulmonary, or CNS function, as fever can aggravate their condition. Children with history of febrile or non-febrile seizure should be aggressively treated to reduce fever. In hyperpyrexia, the use of oral antipyretics along with cooling blankets facilitates the reduction of temperature. This is done because reducing core temperature mitigates the detrimental effects of high temperature on the brain, especially in patients with CNS disease or CNS bleed secondary to trauma. In certain bacterial infection, the withholding of antipyretic therapy can be helpful in evaluating the effectiveness of an antibiotic, especially in the absence of positive culture of the infecting organism. And the routine use of antipyretics can often mask inadequately treated bacterial infection. Furthermore, it may facilitate diagnosis of unusual febrile diseases such as typhoid fever, leptospirosis, drug-induced or factitious fever, where temperature pulse dissociation may be appreciated by withholding antipyretics. In summary, here are some facts to remember. Body temperature is controlled by the hypothalamus. Fever is defined as the increase in body temperature above normal with the change in hypothalamic set point. In hypothermia, the set point remains unchanged and pyrogenic cytokines are not involved. Prostaglandin E2 plays no role in normal thermoregulation, but it starts the process of raising the hypothalamic set point during a febrile disease. Measurement of circulating cytokines in febrile patients is not helpful. Acetaminophen is preferred in the treatment of fever. Treatment of fever with antipyretics does no harm, but withholding treatment may be beneficial in some cases. Here are my references. I hope you were able to understand and appreciate the basic principle behind thermoregulation, the pathogenesis of fever, the approach, diagnosis, and management of patients presenting with fever. Until next time, it's your favorite senior clerk signing off.